Bam. All right. Well, welcome everybody to the 63rd Brainstorm Live event. This is our first event from my new location. So thank you all for transitioning to new registration links and finding your way here. And if for some reason you got lost in the translation and you're watching this recording, let's help you find your way back. But I'm so excited today to be with our guests, our featured authors, talking about strategies for regulating countertransference using EEG. Dr. Kim and I had the privilege of working together on some studies related to neuromyths and neuroscience knowledge. And it's fun to see Dr. Kim's career evolving and now teaching some other wonderful folks that you have with you today. So I will hand it off to Dr. Kim and y'all take it away.
Yeah, thanks, Dr. Beeson. It is very exciting to be here today with my research team crew. And I am Dr. Rin Kim. I work in University of Missouri, St. Louis. Our team member includes Davorka, Rachel, and Liz, which they will be talking about themselves. But I want to start with introducing our research team. I am fourth year assistant professor at University of Missouri, St. Louis, and I started my research team probably right after pandemic when we can actually touch the scalp of our participants. So it's been a year and a half that we've launched the research team for counseling and neuroscience. And this was some of the preliminary results of our very first project, basically using using QEEG to measure the participants' reaction to watching angry client vignettes. And I am still new in running a research team, even though I was a part of the neuroscience research team before and collaborated with other people's, but I could not have done any of this work without my research team members because they bring so much of their expertise in neuroscience, neurofeedback, working with clients with trauma. So I am really proud to share my research team members, and I'm glad to. It's really fun to read the text messages and everybody from all over the place. Hi from St. Louis, basically. But so I will let the work. I'm gonna leave the work at the end because she'll be covering the introduction. So I'll probably take to Liz to introduce herself, and then Rachel, and then the work.
Thank you. I am Liz Irwin. I am one of Dr. Kim's advisees. I am a doctoral candidate at the University of Missouri, St. Louis. And I've been practicing neurofeedback for quite a while now. And my research is in counseling supervision and neurofeedback.
Hi, everyone. My name is Rachel, and I am a fourth year doctoral candidate. And it's been so great working with this team and really happy to be here. I work with clients who have experienced trauma using EMDR, and research interests include PTSD, post-traumatic growth. Yeah.
Hello, everyone. My name is Davorka Marovic-Johnson, and I'm excited to be here today. I have been a licensed professional counselor since 2001, and I am currently third year PhD student at the University of Missouri. And I have many years of experience working with trauma survivors, specifically war trauma. One of the therapies that I implement, it's called brain spotting. And my research interests are relational neuroscience, attachment, resilience, and healing intergenerational trauma. So on that note, because of our collective experience and working with therapists and supervising therapists and doing research, we learned that there is a really high rate of burnout in mental health counselors, and research is showing that burnout and compassion fatigue is affecting not just therapists, but it's also affecting client outcome. It's affecting how therapists show up in a sessions and how they deliver mental health services. So as we know, countertransference, it's that reaction that therapist is experiencing while working with clients, and it can be positive or negative. In our research study, we became interested how our clients' emotional states are affecting therapists. So that's how we became curious into studying countertransference. And in this research, we have a couple of different vignettes. One was angry client scenario. Another one was a grateful client. And then we implemented 2 skills, which I'm going to talk about in a couple of minutes. One skill is called 478 breathing technique. And the other one is compassion meditation. Some of the gaps in the literature that we found. So we found a lot of research related to burnout. However, there is really not enough research that talks about skills for managing countertransference. And based on the research and K-CREB recommendation, this is something that needs more attention. Okay. So let's look at the next slide. Okay. So how can counselors reduce negative countertransference? So we know from research that guided imagery skills like meditation, also 478 breathing technique can reduce countertransference. So 478 breathing technique was developed by Dr. Andrew Weil. I'm not sure if you've heard of him, but he's a Harvard-trained MD. And he was familiar with yoga and kind of Eastern medicine. So he implemented this technique, which based on research shows that it can reduce anxiety. And as we know, when we reduce anxiety, we reduce the high beta activation. It can improve executive functioning. It can help with emotional regulation. And then compassion meditation, there has been a lot of research done on this particular meditation. Specifically, I'm thinking of Dr. Richard Davison, who is at University of Wisconsin in Madison. And so what we know from the research is that compassion meditation increases self-awareness, empathy, altruism, and social emotions of fairness and cooperation. Breathing exercises also, just same as compassion meditation, can increase alpha waves, they can reduce beta waves, they can also increase theta brain waves, they can improve emotional regulation, stimulate vagus nerve, reduce depression and anxiety, and also improve executive functioning. Okay, let's look at the next slide. Okay, so I assume that most of you are familiar with the brain waves. So I'm just going to briefly go over it. So as we can see from the chart, delta, theta, and alpha waves are slower waves. So we know delta is present when we are asleep, like that deep, deep sleep. We also know from research that delta is present in children from 0 to age 2. We also see lots of delta waves in developmental trauma. Theta is that kind of drowsy pre-sleep state. It's present before we fall asleep during deep meditation. Research also shows that children from age 2 till about age 5 are operating a lot from this theta brain wave frequency. And I feel this is important, especially because we know that 90% of our brain develops by age 5. So if something entered into our subconscious or those subcortical parts via that frequency, I feel this is important to keep in mind when we do our research. Alpha is that bridge between internal and external world. It's present during meditation and breathing, kind of when we kind of slow things down. Beta, it's important for focus. But if we have a very high beta, we that usually connects to anxiety, and anxiety can affect all those brain structures and negatively impacts our executive functioning and relational skills. Low beta, it's connected to ADHD. And then gamma is kind of interesting. We know they are kind of associated with superhumans. So we see that like a Buddhist monks who have many hours of meditations have a high gamma activity. So this is something that I feel like it still needs attention. So we also found out that research shows that people who are trained in like a theta have a better memory compared to those brains that are not trained. And also we know that breathing exercises and meditation, as I mentioned this earlier, increases alpha and theta waves and reduces beta. And this leads to better attunement and emotional regulation skills. I also want to mention that I have found research that talks about when you are in a high beta activation, that opens kind of doorway or windows into other states that correlate to that current state, which kind of makes sense, right? If you are highly activated and stressed out, then you start thinking about other events or other memories that trigger this current state. I feel this is important to keep in mind because research shows the more we stay in that state, we kind of make those neural pathways stronger. So how do we interrupt that, right? What do we need to do to change this state or implement skills that can decrease this high beta activation? So that kind of that connects to our research as well. Okay. So research shows that neurofeedback training can significantly increase emotional regulation. And something else I want to share. Okay, so research also shows that neurofeedback training can significantly increase not just emotional regulation, but it also it shows that resting state functional connectivity within the emotional regulation network and prefrontal network improves, as well as between emotional regulation network and amygdala, which we all know is responsible for emotional regulation. Okay, and let's look at the next slide. So our research question is, do the brain activities significantly change before and after each intervention? For example, in our case, as I said earlier, we use 478 breathing, compassion meditation, and seeing a grateful client. And as we know from research, our brains are shaped and influenced by both positive and negative experiences and emotions. And breathing exercises and meditations have been linked to positive changes in the brain and gene expression in a way that improves overall health and well-being. That's all from me for now. And the next is Dr. Kim. Thank you.
Yes, thanks, Aborka. I want to stay a little longer on the research question slide, just because this really leads our data analysis parts and then the implication of the study. But we talked about how neurofeedback can be one strategy to regulate emotions, and I am interested in potentially doing an outcome study of neurofeedback. And at the same time, we're aware of the what might be some barriers to implement neurofeedback in counseling education sessions, education setting. So we focused on, instead of long-term interventions, we focused on something that counselors can do briefly, relatively briefly, hopefully between sessions or like during their workday. What's really helpful as almost like a quick solve. Is there any strategies there that can be a quick solve to kind of regulate their emotions or regulate their reactions to countertransference? So with that, so this was the procedure. I'm also very aware of the barriers and process that we have to take as a newly launched research lab. So we picked a single case study. So we have a participant of 1, and we use the ABBA research design. So we have 6 different client vignettes before and after each intervention. Of course, we got IRB and we did screening survey so that we make sure our participants meets the inclusion criteria, which included 18 years old or older. And also we wanted to start with a counseling student who are currently seeing clients either on their practicum or internship. And our participant is someone who is seeing clients during the internship. And we wanted to find somebody who doesn't have high scores on their depression and anxiety scores, just because the literature, especially with the anxiety scores, just because the literature said there's a high correlation between anxiety and reacting to like scores in countertransference. So we wanted to make sure we're not including our inclusion criteria says that basically a score lower on the GAD. And we did EEG recording with the interventions, including 478 reading technique. And one of the vignettes we saw as one of the intervention is to seeing a grateful client. And honestly, our vignettes were like 12 to 14 seconds of client actor, an actress who played a role of being an angry client for 12 to 14 seconds. And also the seeing a grateful client vignette was the same actress acting on the client being grateful for about 20 seconds. And then the last intervention was compassion meditation. So I kind of mentioned this before, but we had a participant of 1 who was a white female counselor in training, and our inclusion criteria was that like those who currently seeing clients and right-handed, normal developmental history, which means no history of concoction and seizure, and have scored lower on PHQ 8 and GAD 7. For the measures, we use PHQ 8 and GAD 7 as a sub-report, but also we wanted to see how the participants kind of self-evaluate themselves with the emotion regulation. So we use that before and after the whole EEG recording. So when she first came in with, we explained everything, and then she completed the self-report before we connect to the EEG device. And then after everything, she also completed these 3. In terms of EEG, QEEG, we use asymmetry on C3 and C4 gamma waves. There are reasons for choosing this particular measurement. There are some areas that are related to emotion regulation that includes F7 and F8. And so C3 and C4 is not the only location that kind of address emotion regulation, but we chose C3 and C4 because that C3 and C4 is kind of away from eye movement artifacts. So we chose C3 and C4, and we've done data analysis with alpha waves as well, but was also advised to use gamma because gamma is more stable as a measurement compared to alpha, and there are some citations and research saying that gamma can be a good alternative of use of alpha waves as an assessment. So we took we did gamma waves, and so that was the equation that we used to create that asymmetry score on C3 and C4 gamma waves. And let me talk a little more about asymmetry. Asymmetry can be really, of course, we use descriptive statistics with the self-report measurements, but for the asymmetry, the reason why I wanted to use asymmetry is, one, realistically and honestly, it's simpler than other advanced data analysis, and also it gives us very insightful information about how the reaction of the participants. So if there are more activation on left hemisphere, so in this case for us, it's going to be C3. And if that happens, it's known to have like activation on left hemisphere means there's more approach, accepting, liking, and preferring. So in our case, when there's higher activation on C3, that means the participant is more inclined to kind of wanting to approach to the angry client. And if we see lower scores in asymmetry, that means there's more higher activation on C4. That also means like kind of rejecting and disliking and avoiding towards the angry client. So it may get confusing when Liz is talking about the results, but what really important thing to be mindful is that higher score in asymmetry score means higher activation in left hemisphere. That means you're more approaching to the stimuli. And so we wanted to compare the asymmetry scores before and after each intervention. And we used Wilcoxon Signs Ranks t-test to compare the median scores before and after each intervention. I wanted to use the dependent t-test, but the normality was not met, so we decided to use the Wilcoxon Signs Ranks t-test. And we examined whether there is a significant change before and after each intervention.
Hey, so Rin, can I ask a question?
Yeah.
Yeah, did you all distinguish between like positively and negatively valence countertransference, where like I might find myself affectionate towards a client, so that might be positive valence countertransference versus, you know, another form that might be, oh, you disgust me, kind of negatively valenced countertransference?
It's a really good question. We didn't ask her reaction specifically. Self-report was mainly just like numbers rather than what do you think? What are your emotions towards?
Gotcha. Cool. Thank you for that.
Yeah.
I actually have, I've been holding on to a similar question, and that is, does the person's self-awareness of their own countertransference, does that have anything to do with this, particularly on a practical level? If not the countertransference, how about self-awareness of, say, anxiety, discomfort, or other feelings, even though they may not recognize the source?
Mm-hmm. Yeah, that's a really good point. I think partially it might have been captured with our emotion regulation self-report, but again, it's very numeric values. It's not about our self-awareness. We're still recruiting. We're actually in the middle of scheduling another participant for a licensed professional counselor with the same protocol. So it could be a good addition to kind of check in, maybe not as like a formal data, but to talk about person's self-awareness on reaction, like their reaction to the vignettes.
Yeah, I'm gonna go ahead and take, because I get this great opportunity to go over the results with you. And Laura, I actually think that I'm wondering what you'll think after I give the results too. But so the results were really fascinating, and I think kind of not what we were expecting initially. So as we're going over the results, I want to first tell you about our participant, so a little bit more about her. And so like we already mentioned, we gave her the self-report survey. We gave her these 3 self-report surveys: emotional regulation, generalized anxiety disorder, and patient health questionnaire. Emotional regulation, that's exactly what it says. Emotional regulation, one's ability to emotionally regulate. But there are 2 subscales: the cognitive reappraisal and then the expressive suppression. Cognitive reappraisal is the ability to basically have something seemingly negative happen, but then being able to reframe it so that it feels more positive. A great example of this that I like, that one of my teenage clients told me once, was that I got a bad grade on my test in class, but honestly, if I had to get a bad grade, I'm doing pretty well in this class. This was the place to get the bad grade, so I'm happy with that. So the ability to reframe, cognitive reappraisal. And then expressive suppression. What that's speaking to is just distress tolerance, being able to feel some way. It could be good, it could be bad, being able to have some, emotional response, but then still be able to regulate and then be able to engage with an environment, with your external environment, in an optimal way, despite the emotional response. So with our client, with our client, word gets stuck in my head a lot. With our participant, what we saw was that with all of these, with the ability to emotionally regulate and both subscales, with the anxiety and with the depression as measured by the PHQ, when surveyed both before and after the study was complete, she scored within normal limits. And so was able to emotionally regulate, very limited anxiety, and we also asked her to self-report. As mentioned, we asked her to self-report on the helpfulness of each one of these interventions. So just a reminder, the interventions that we used were the breathing technique, the compassion meditation, and staying grateful. She identified each one of these as extremely helpful, 5 out of 5. She thought they were all great. But then we also asked her to rank them. And in ranking them, she identified that the breathing technique was the most helpful, followed by the compassion meditation, and then followed by seeing a grateful client. So her subjective analysis of this was that breathing technique was the most helpful, seeing a grateful client was the least, but all were. So moving on to the next slide here. Okay, so I just went over the subjective data. Now I want to go over the objective data. Broad overview of the objective data is that seeing the breathing technique was not helpful. Like, we did not see a decrease in her activation. We did not see a decrease in distress after the breathing technique. What we actually saw was an increase in a desire to push away, right? A desire to avoid and kind of reject after the breathing technique. With the grateful client and the compassion meditation, we did see her ability to regulate after that. We saw a decrease in distress after that. Now, so Rin mentioned earlier that this might be a little confusing, so let me just repeat a couple of things just to make sure we're on the same page. So if we look at that mean score there, with each of that mean score, the first duo, so angry client 1 versus angry client 2, we're seeing a decrease in that number, 1.06 to 0.9. We're seeing a decrease in that, and that is measuring the gamma at this C3 versus the gamma at the C4. And so we're seeing a decrease in gamma at C3 there. Once again, that decrease indicates an increase in distress, an increase in desire to avoid, right? So it's a little bit backwards. So if that makes sense. So once again, that breathing technique, we saw a decrease, which indicates her distress actually increased. Fascinating. And then with the grateful client, the compassion meditation, we're seeing an increase in gamma at C3 compared to C4, an increase indicating a decrease in the stress. So those were effective. Those actually did decrease registry. Let's go ahead and move on to the next slide here. So the next slide here, once again, interesting. We're seeing that each one of these was statistically significant. The grateful client and the compassion meditation both were statistically significant in her ability to emotionally regulate afterwards. So in the gamma increase at C3, that was significant enough to say, yeah, this could be an effective intervention. However, with the breathing technique, we're also seeing a statistical significance there too, right? But we're seeing it in a decrease in gamma. So once again, a statistically significant change, but in the decrease in gamma, once again, we're seeing greater distress. Okay. So moving on to slide 14 here. So these results are kind of fascinating, right? Like she is identifying that she is, based upon that emotional regulation, the results of that, she's identifying as somebody who is highly emotionally regulated. However, what we're seeing with on the EEG, on that raw EEG, gamma at that raw EEG, is that she became pretty emotionally activated with angry client 5. It's interesting. And then also her self-report about which of these were most helpful. Really, the one that she reported to be the most helpful, we actually saw the opposite. We saw that not be helpful. It's fascinating, and we have to be curious why. My questions were going to, or my thoughts in trying to understand this a little bit, were going to 2 places. One was interoception. Is she accurately identifying her distress? Does she have the self-awareness to do that? And I'm curious about like continuing to look at that and maybe the next steps in exploring it too. The second is the data, right? As Rin mentioned, these aren't the only places in the brain where we can measure emotional regulation. Also, this isn't the only way that we can measure emotional regulation. So would this incongruence make sense if we were able to see the other placements of the brain and also those other ways? We would be able to make sense of some of this incongruence in our data, the subjective self-report versus the objective, the EEG. And so, yeah, that's where I'm at with this. And I'll hand it over to Rachel.
All right. I'm going to move on to the next one. Okay, so some of the contributions of the study include that countertransference management research has typically been focused on self-reports, yet the data supports brain responses to each stimuli. Also, our study adds evidence to what happens with regard to and what works for emotion regulation. And it emphasizes the importance of this type of research for the counseling practice and field, as well as potentially being helpful in learning what's useful in regulating brain reactions, such as intentional scheduling and compassion meditation, as we discussed. Dr. Kim, if you would jump a couple. One more. Thanks. Okay. So some limitations of our study include that it was a single case study and can't be generalized to the greater population. Also, our plan was to actually use 19 channels, and the results that were revealed include only 2 channels. Also, there's the possibility that a participant held biases of gender, age, or the stereotype of an angry Black woman, which could have influenced their reactions. Additionally, our angry client was an actor, and the participants' reactions may not portray an accurate response when compared to counselors reacting to an actual client. And also an acknowledgement that the recording of our angry client was through the computer, and taking into consideration the differences between telehealth versus in-person sessions, for instance. Next slide. All right. Our future projects may include licensed clinicians as opposed to counselors in training, which, as Dr. Kim shared, we are currently pursuing and feeling really excited about. As well as formulating generalizable study design towards the normative population, as well as clinicians with trauma histories. The applications for practice are intentional scheduling and short compassion meditation. So for example, if we were to work with clients who often activate us, we may find spacing out time before our next client to allow for us to ground ourselves and re-regulate our emotions beneficial, and or engaging in a shorter iteration of compassion meditation, so less than 30 minutes. All right. A couple resources for what we were discussing.
And we have a bunch of references, and as I did mention it on the chat, but we'll be happy to share the slides with you. And oh yeah, there we go. Yeah. So yeah, that was our study. I think we kind of mentioned we probably yeah, I just want to mention that the participant came in for an hour appointment to record and complete the EEG recording. And when she came in, she saw basically based on the baseline, she watched angry vignette 1, breathing technique, angry vignette 2, and then had like a break of 1 minute, so to kind of clear her mind, and then do angry vignette number 3, and seeing the grateful client, angry number 4, and then another break, angry number 5, compassion meditation, and the last angry 6 vignette. So yeah, we'll be happy to hear about the audience, about the feedback, comments, questions.
Hey, so Rin, what equipment did y'all use?
We use Discovery. So we do have a 19-channel data. It's just taking some time to actually use the data for analysis.
I have to say that I'm particularly interested in practical application of your work as a clinician, and yes, Liz, you're right. What you presented was really interesting in light of the question I asked, but I do think that that slide that you had like 2 slides ago about the practical applications, I think it really does so depend on the therapist, the clinician's self-awareness. And I wonder what it suggests to me is, say, if I were the clinician who wanted to take advantage of this, which I am, I would maybe build in a moment after a session to notice how I was feeling, to take a look at myself. And even though I may not have the opportunity at that time to understand where my feelings were coming from, at least to note them, and maybe even to do like a little diary of it, just to help me know when and where to use the tools suggested by your research.
I just wrote down, because that will be a great thing to mention it in our, like, as an implication of the study, because yeah, we wanted to bring some tools for clinicians as they try to navigate this intense feelings after working with some clients with intense emotion. But yeah, like I don't think the self-awareness was a big part of our project design, but yeah, that's so important to start anywhere. And I appreciate, oh yes, go ahead.
So yes, the results and the testing you're doing is very, very interesting and certainly shows a lot of valuable, potential in terms of helping us. I'm a clinician, LPC. It's interesting the question that was asked in regards to like, was it back to back and so forth like that? Because I know for me, understanding certain clients have the potential of being very triggering because of where they are with their trauma or their situation. I will schedule them at certain times of the day versus others because I know they're going to take a lot more intense energy from me to stay in that state of being able to reframe and not get continue to get escalated internally myself. And so it'd be an interesting factor to understand how time of day or how after how many cases of clients, the ability to self-regulate and the amount of countertransference plays into it in terms of those factors. Because I think Eric noted in the chat, I mean, my gosh, you guys are doing amazing work, and there's so many variables to try and get down to a succinct number that you can control and really get true results from. That's a lot of work for you guys, so kudos on doing that and attempting to give us this really good information. And that incongruency, that's very surprising about the breathing. I don't know what to think about that or what to do with that, but it's very, very interesting to find that out.
I wonder with that one, the first one, because our first vignette was an angry client, and then the breathing. I'm just wondering if the counselor in training was dysregulated. So because that was the first technique that she experienced, maybe it just took a while for her to reduce the high activation.
It could be that really because the breathing techniques, was like 1 or 2, I think it was like 2 minutes versus compassion meditation was basically like 20, 30 minutes. So like it's probably time can be a factor, but also Eric said breathing can also be activating and noticing even more about her reactions. So it is fascinating. And the incongruency was really struck me in the team. Like, what do we do about this? Like, what do we do with the results? But it kind of makes sense because our brain and what we perceive may not always be on the same page.
I also wonder with compassion meditation, we are hearing words, may you be happy, may you be safe, may you be loved. And I wonder, hearing that, how is that really also impacting versus breathing alone?
And did they close their eyes at all during any of those?
She became pretty sleepy during compassion meditation. I would, yeah.
Yeah, I think part of the instruction of this recorded meditation is probably sit, comfortable, and if it helps, close your eyes. So yeah.
Yeah, no, I mean, because there's always, I remember when I was getting trained in neurofeedback, they would say things like, this changes your brain, that changes your brain, and they would always be like, so does closing your eyes. And So kind of thinking about just all those little differences that cause changes, and change isn't really, we're trying to understand what that change means within these diverse contexts. And, so Rin, you've got so much more work to do and so many other variables and replicating at scale. And I know you mentioned sort of those future directions. So did you all get any money for this one, or is any money coming your all's way so you can actually do this at scale?
Wonderful question. I've used my startup funding to implement this study. We still have some money to recruit one more participant and then provide basically compensation, Amazon gift card. But it will take, and because our device and the setting was funded by my startup funding, and because we have the setting, it will take less funds to replicate or develop the study design with more control. So.
Yeah, just a time resource investment, right? So thank you all for doing that.
Right, exactly. I wish there's 48 hours a day so that we can do all the projects that we have brainstormed.
For all of you EEG brainiacs, I wonder, are there any individuals whose anxiety may be affected just by, as you say, when your fingers are touching their head? In other words, just the application of the equipment, perhaps a self-consciousness, or like, uh-oh, I'm being evaluated. Is that all kind of considered in all the work that you guys do?
Yes. It is very uncomfortable with the 19 channels and gels on your hair. And then I intentionally choose to have a not really comfortable chair for this type of research because we don't want our participant to fall asleep while watching the stimuli. So we try to we acknowledge those uncomfortableness, like the first time we contact them, we talk about the jaw and how it can be uncomfortable. Yes, Eric, absolutely. I had one of the projects, I saw I was learning tips on doing these research, and then we also wanted to dim the lights, so it can be a great place to take a nap, and if you're using really comfortable chair, and then yeah, it's a perfect company. And one time I had a participant who were just checking the phone, so oh, it's good to know that next time I'm telling them to um, let's put your phones on the airplane modes and then put it aside. But yeah, all kinds of things. And at the same time, we're checking in with them where we're wiring them with the device. How does this feel for you? And then making some using some humor to oh, I'm sure you're very comfortable right now with all the wires, and try to have some time to adjust. And we don't start. Well, I think part of it is the baseline for 3 minutes eye closed and eyes open. Kind of helps them grounds the setting of the EEG device and the wiring. But yeah, that was one of the reasons why we had that 1 minute break in between the intervention, because we're not using that 1 minute because she's been moving around and then kind of stretching. So yes, definitely there's anxiety and at least uncomfortableness with the setting. that a hand? Yes.
Yeah, I'll talk forever if you want me to, or ask questions. But I'm curious about there's a couple reasons why this comes up for me, this idea of congruence versus what I self-report versus what the EEG is said to mean, right? And I know you all consulted with at least Tom Clore's research, and I know he probably consulted with you on the analysis in some way, but they wrote that article a while ago about sort of, I think it was asking clients things about food, and they started to see some indications that there might be some aversion to that conversation, and the client had never talked about an eating disorder before, but they were able to then talk about that and say, hey, when we were talking about food, I noticed this. And then that started up this conversation about, well, yeah, I had this complicated relationship with food in the past. And it kind of brought up this idea of a couple different things. Like, one, is that valid? Is there validity to that disagreement between self-report or disclosure and, what a brain EEG reading might say? But two, also some of the ethics and like unintentional self-disclosure and things like that. Like, does a client have the right to not disclose that to you? And then does that EEG signature, if you will, kind of, impede upon that in some way? So I'd love to hear y'all's thoughts, just because you're starting to see and play around with some of this congruence, incongruence piece. And I wonder how y'all would conceptualize that as you're working with clients, as you're working with research participants.
Yeah, honestly, I've never thought about that ethical consideration of the client's rights not to disclose, because part of me think that the client can also say, well, I don't know why it happened, right? Why it activates more when I said talk about food. So like I think there's still a choice unless we are a magician and then read the raw EEG data, which we're not. But yeah, like I've been thinking about like the incongruency between self-reports and EEG recording, but that doesn't always mean that participants are lying though, because we're only capture like a few seconds, especially if you're using like ERP, then we're really capturing the first reaction. And this participant who scored relatively high on her emotion regulation, like she might be able to regulate her emotion like maybe a few hours later or like a few minutes later, after, for example, like after 2 minutes of breathing, maybe after like right, like it within that 1 hour frame, she was able to kind of regulate herself, and we cannot, well, we did our best to kind of capture her self-reports and then kind of have this like understand her better in the nuances, but we didn't control, like we were not able to control every details, and so we don't know if the emotion, so higher activation in left hemisphere, we can't say 100% that it's solely because of each intervention. And still, she might be right? Like even though there's a discrepancy, like maybe the next day, it's like she feels better about it and she has her own strategies to recover from it. So I think there's an incongruency that we're observing, and I think how we take it and how we interpret it and then applying it into practice is, we need caution, because it can be judgmental when we say, well, there's an incongruency. It doesn't mean you're lying to your self-report, but that may not be true. That's not probably what it's actually capturing.
Yeah.
If I may, the client I had just before Brainstorm today was a great example about what you just said without the EEG part. What do I mean? Well, I noticed there were nonverbal communications to me that something was going on, which I noted, and I kind of gently asked, and without being, confrontational at all. And it was pretty amazing where we went. However, I will say, the point being that facial expression, body, the eyes moving around, stammering, all the nonverbals that I understand with this particular individual. Okay, it was very communicative to me, and I needed to make a decision about where to go and what to do with that. I had a feeling I knew exactly where it was coming from, and this client did not. So the point being that there are, I think, if he had an EEG stuff going on, that maybe would have been consistent with what he was communicating. And it's just kind of a how shall I say, old school way of working with the same kind of information that you're talking about. Does that make any sense?
Well, Laura, what you're saying.
I'm so sorry.
Go for it, Liz.
I was actually having kind of a similar thought with this, right? Because if we're exploring, we feel good with our client. We feel like we're kind of killing it, but we're also seeing a high level of burnout, right? Or we feel like we're doing a great job with our clients, but man, you know what? I kind of get a headache every day too, and I'm having a hard time really calming down at the end of the day as well. It's reminding me of that square that I can't remember the name of at this moment, where it's like the self-awareness square, right? Like one quadrant is what I'm aware of and what other people are aware of. The other quadrant is what I'm aware of that people aren't. And the other quadrant is what other people are aware of, but I can't see. And that fourth is like the unknown. They don't know it, right? But I think so much of therapy in general is about increasing that quadrant, that being able to increase one's awareness to their blind spots, so that the stress then doesn't come out in burnout, and maybe sometimes accidentally getting a little angry at the client in session. We're human, sometimes emotions seep out, or not being able to sleep, or depression, right? Like, so by being able to increase the awareness, maybe using EEG, not to say you're wrong about what you're feeling, but maybe more to say, this is interesting. What do you make of this, right? Let's explore this together. So and that's kind of where my brain is.
Yeah, as you guys talk, it's interesting to me, again, kind of getting back to that incongruency thing with, and I think about the breathing piece of it. And I'm wondering if in doing the breathing, your focus is to bring yourself back to a level of calm. Bringing yourself back to a level of calm in that focused breathing is probably processing different. You may feel better, but the fact of the matter is, if you're doing a compassion meditation, I'm wondering if that isn't so self-absorbed. In other words, if you're doing a compassion meditation, then maybe a part of you is focusing on, compassion of self and others. How do I relate this to my client? And in just that kind of reframing, if you will, in the mind, you're actually being more, it's having a more higher positive effect than just the self-absorbed trying to regulate breath within yourself. And the same thing is probably true with the gratefulness. Again, it's not just, you're not, focusing on the gratefulness as a you thing, but more probably grateful that's more inclusive of your client or other things in the world outside of yourself. And that connection may influence what is really going on and contributing to the true EEG results, versus what you're thinking is helping you, like with the breathing, when in reality it might be the other, because there's the connection piece versus just the individual attention piece. If that makes sense to anybody.
It makes sense. Listening to all your feedback, I was thinking about some other study that maybe can be interesting, discussion. So as I mentioned earlier, I am also interested in healing intergenerational trauma. So I have done some research in the past and workshops. And I'm not sure if any of you are familiar with the cherry blossom study done at Emory University. Have you heard of it? But, talking about why somebody has certain reactivities, some information can be really unconscious, stored in our DNA. So this particular study at Emory looked into how trauma is passed down from one generation to next. And so they used mice, and generation one was exposed to smell of this chemical that smells like cherry blossom, and simultaneously like this negative stimulus to their feet, like a symbol of shock that is in their feet. So of course it makes sense that generation one had that adverse reaction each time they smell this cherry blossom chemicals, right? But what the researchers found out with their offsprings, they also had negative reaction to even, to this cherry blossom smell, even though they never had any adverse, they never had shock to their feet. And not just that, when they look at their brains change. There were more neurons whose job was to detect cherry blossom. So the reason I bring this up, like when we think about why some of our subjects or counselors in training or in therapists that are going to participate maybe have certain reactions, it could be something else that's contributing to this reaction.
It's so important for that secondary question of like, and so Rin, you said, reminding ourselves to be cautious and not like over connect to any one piece of data or assign some valence to it, and really just kind of ask the secondary question of like, I wonder where that came from, and kind of ask, because as Dvorka, you're mentioning, like that where that came from may be outside of anyone's awareness, and that may be generations past, right? So kind of, I think it's another nod to also not over individualizing pathology or responsibility for recovery too, and just kind of thinking about, I'm a complex intergenerational being that's come to this space right now and is having this reaction to this one cherry blossom or whatever it is, right? So I mean, I think that's some really strong stuff that, just kind of looking at that congruence and self-awareness, as Liz, you talked about. Sometimes we assume there's some negative lying, something like that in that unaware space, when the reality is there may be no way they could have accessed that awareness for whatever reason. You can't interview the second generation mice and say, tell me about those cherry blossoms, what happened there? Why'd you have such a scared reaction to those cherry blossoms? I don't think the mice are going to tell us anything from their generational history. Or their present day awareness. So thank you all for joining me in that like little kind of exploration through that congruency piece. And Laura, something you said really resonated with me in terms of like sometimes we get so bent out of shape because it's a neuroscience based method, but we've been using our observation and immediacy skills for generations. And to me, this is just a new kind of immediacy, a new kind of observation. I think there's still some ethics to think through, but I don't know that it's a bad thing to introduce another layer of observation to our repertoire, to an individual's self-discovery or our clinical interventions. You know, and we're using the same skill. I notice this and I wonder what that means. Like those are skills we would do when I see eyes move or knees shake or anything like that, right? So now we're just saying, I noticed, you know, C3 popped up there. I wonder what that might be telling us, or I wonder what might have happened there, right? With that curious space. So I think that really gets me excited to think about not just what does the reading say, but then what meaning is constructed around it. And that's why I think counselors are some of the best neurofeedback practitioners, because, you know, it's just one part of the story that you unfold and evolve in this really cool meaning making framework, if you do it that way. Not all neurofeedback practitioners do it that way, as you all know, but I think there's something really special about the way that a humanistic framework can be applied, even in a very technical, or what might seem like a very technical application. What are your all's thoughts?
Eric, I think your comment is, cautionary tale. I haven't been in school for a while now, that I know that for myself, if I learn something new, I tend to, how shall I say, maybe a little bit let go of the old stuff and really be about the new stuff. And hopefully the things you're saying are part of the education, that, hey guys, this isn't to replace that other thing. It doesn't mean that you have to let up on your skills of noticing and really focusing on your client. One of the things that I was thinking about that's so cool about all this is that if the therapist is triggered or otherwise affected by the client, that takes their eye off the ball. It takes away their ability to, then it becomes, even though it's not conscious necessarily, but it becomes about them, not about strictly, taking the opportunity to get information about my client in every moment and really listen to them with our eyes, our ears, and everything. Because if I'm sitting there thinking, gosh, this guy is a jerk, I don't mean literally. I mean, you know what I mean. But if there's that countertransference, or even, gosh, if I were 20 years younger, any kind of countertransference, it's so important to just notice it, to let it go and come back to what our job is to be present. So thanks, Eric. I think, I don't know how much emphasis, the idea that this is a new, exciting resource and layer of information as opposed to replacing the old stuff, that's really reassuring to me.
Yeah, I also really appreciate that, Laura and Eric as well, like talking about the narrative that we give the data and looking at that compassionately, especially since I'm a clinician as well. And it just really helps I can imagine it in every level of training. From the very beginning, when we're training counselors in training, what is countertransference? How does it show up, and how we can use it? Because we often create this narrative that countertransference is the worst thing in the world, and it's a terrible thing that you do to your clients, when it's just like, we are people and we react to things. And there's some things that we really need to pay attention to. You mentioned like stereotypes or racism might be one of those things that comes up and lights up our brain. Those are things we need to pay a lot of attention to. That like I think about that for myself as a white clinician. And there's any kind of reason. So being female, having male clients who might bring up feelings of concerns about safety. That's happened to me as far as countertransference goes. So I just wanted to express as a clinician just working out in the world how meaningful it is for me that people, and one of the reasons I love this space is that there's this bridge that people are researching us. And they're researching our experience, and they're researching what's best for us and what we can do to be the best clinicians that we can, but also what affects us and damages us. So like, if I can gather research that can like advocate for policy that says the exposure, no matter these little individual interventions that we do for ourselves, like meditation is not going to fix capitalism kind of idea. Where like the corporations and the companies are like, oh, here's your yoga, now stop asking for money. But if we can start like showing through data how clinicians are affected by workload, by burnout, by trauma, by exposure, and that these interventions might do something on an individual level, but systematically we need to advocate for clinicians to have lower caseloads, for them to have living wages, for like those are the interventions that are actually going to reduce burnout. And I know that that doesn't fit neatly in an hour with your with the CAPA, so it's harder to study, but I just genuinely appreciate so much people researching what is good for us. Because I think that we don't pay, like, why am I emotional about that? You should put a thing on me. Because I've experienced burnout, and because it means a lot to me that people are looking into it.
That's
Well,
really encouraging. Thanks for saying that. Yeah, go ahead.
Yeah, it's interesting what Kate was saying, because it's been a few years since I've been in school, not decades, but I still look back at what is the reality of practice and what was taught in school. And they make statements, well, it's not a matter of when, it's a matter of you will, or it's not a question of if you will experience burnout, it's a matter of when you'll experience. Hey, that's great information, but what am I supposed to do with that? It does not say what's that look like, what am I supposed to do when that happens? Even just educating counselors to be on how to recognize it and how to develop some of these things that you guys are talking about are really workable interventions for ourselves, rather than just this nebulous, oh yeah, I mean, all counselors will get burned out sometime. Well, okay. But if I don't know that, I can't be preemptive. That gives me that's a fear-based induced trauma waiting to happen, so to speak, because now you're like, oh, it's going to happen. When is it going to happen? What's it, oh, what am I, then you've got that going in, rather than having the knowledge how to be proactive in identifying when it's coming about, and how to prevent it from coming about. I don't want to buy off into the idea that everybody's going to get burnt out. That may be the case, but do we have to address it from such a negative, standpoint, versus we're teaching our clients tools on how to be in well-being for the rest of their lives. Why aren't we taught those tools so that we can model and affect more positively our clients, as well as our own ability to be good counselors to them? So that's my soapbox on missing the boat
Yeah.
a little bit in the education field.
Yes, I loved it. I loved it. One of the things that I noticed is that by a lot of our master's level students, well, also doc students too, they're working full time and then part-time schooling or even full-time schooling with a job or two or three with family. So they're already taking on a lot. And sometimes I feel like when we talk about wellness and self-care, it almost sounds like we're putting one more thing on them to do while squeezing this, for example, like breathing techniques or compassion meditation on your already busy schedule because that's important and that's what you should do as a counselor. So I liked our actually what I like about our study is that having that grateful client. So like just being intentional on your scheduling and then like just being intentional of your you're advocating for your work schedule and then which I think it came up in our discussion, but like kind of being intentional, like when I see this more energy provoking clients, like not putting them together on the same day or like back to back. So we right, to practice 30 minutes of medication daily. And so I say that maybe your self-care looks like where do I where do I say no? How do I empty my calendar? Maybe that should be your self-care. And I agree so much that we're talking about it to our clients, but maybe we're not the best on practicing on ourselves, but also as a counselor educator, maybe not practicing on assigning those assignments to my students.
So
I
Rin,
love that, Dr. Kim. Thank you so much. It just like in Eric, I also loved your comment because I was like, it made me think of like this helplessness. And Melissa, you shared this like the helplessness, like, oh, there's nothing we can do. These train conductors just keep falling asleep at the wheel. There's nothing we can do.
Yeah.
And just having data like this, like harder data that people in power are going, unfortunately, more likely to respect than the continuous complaints of their employees. And I've worked in huge systems where like the employees have made the same requests over and over and over again. The second they have a consultant come in and say the same exact thing, now all of a sudden it's a good idea. So like having harder data that can say and support these kinds of policies around what is going to be good for clinicians is just awesome.
Pete, I liked how you gave the nod to sort of capitalistic philosophies, and some might say that drives much of this conversation because it's all about productivity and, profits and all those things that drive us to work as hard as maybe we do work when that might not be the best for us. So Rin, didn't you all do some ERP study related to counseling students and reactions to different color faces and things like that?
Yes, it's in progress. We're finding a good home for that manuscript. It's been only one rejection so far, so we're gonna find a better home.
Yeah.
But yes, we did a study on basically showing the IAP, which is implicit association test on race. I think it's pretty sure it was race. And that pictures are black and white. But we also had a list of picture of like in color. And I think it was like some roster from a university, and then we saw an ERP like reactions to each picture that includes IAT tests, and then pictures used for IAT tests, and then the colored version, and compare the results. I think it also relates to incongruency that we've talked about the self-report of like their potential biases against each picture, and also the IAT results. And they're not always congruent, like
Yeah.
between the self-report, even IAT results that is supposed to capture the implicit bias,
Yeah.
and then the EEG recordings.
Yeah.
It was also a case study with three participants, but like the same thing, right? Like that doesn't always mean that they're lying on their self-report, but because we use the ERP, which is like within that 300 milliseconds,
Mhm.
so their initial reaction may be not the same as their self-awareness, and probably their reaction to IAT, which is within seconds. So yeah, that's where we'll see where
Yeah.
it lands eventually.
And that's what I'd love, to see you all or people in neuroscience to do, is like capture the processing of the presentation of the results in the study results, right? So this is what we noticed in your results. How do you respond to what we noticed in your response? Like, I think that part of data collection, like, I mean, you don't see in a lot of the hard neuroscience publications that you're going to see out there. But like, I think you all, and that's why I think counseling as a field has a tremendous opportunity to like, what would we bring to this method of research that's unique and different, and captures different kinds of stories that are not just about signed Wilcoxon rank tests, but are about a little bit beyond. How does a person respond when you tell them they had a statistically significant reaction to a black face when they say they're colorblind? Like, that would be a really fun piece of data to continue to collect along that way. So I don't know. I'm never going to do it probably, so I just keep saying it out loud. So hopefully someone will do that kind, because I would love to read it in my career. And like Kate said, I think that's the stuff that would help us is, I need to identify those 300 millisecond reactions that I have, and then how I make sense of those 300 millisecond reactions that I have. I don't know that we can ever really take away the 300 millisecond reaction, but we can probably change the way that we make sense out of that 300 millisecond reaction.
Yeah, and plus, like we can't have the like EEG device with our clients every session and run the analysis and show it to their clients that's just not
Yeah.
realistic, or like that's just impossible. But like with that piece of information, we counselors can apply to practice and then just provide the food for thoughts and food for better self-awareness for clients, but also for clinicians. So I think we're good at like applying and then applying to practice, like with that a little piece of information about 300 milliseconds, like that doesn't mean that we need to change anything about our reactions in 3 milliseconds, but like what are the applications and what the implication in understanding clients better.
So when you guys run out of things to study, how about what happened? Okay, we're talking about the millisecond response that is detectable with an EEG. To have a list of all the possible how we respond to the response. What do I mean by that? Some of them, some people are better at, say, compartmentalization than others. Some people are great, and I don't mean consciously, at denial. Then there's a whole big chunk of stuff that is protection, right? Ways that we keep ourselves from having awareness of our feelings or of our response. I would love to see the list of all the things that all the automatic responses we have to responses, all the possibilities. Does that make sense?
Yeah, and I'll like, I mean, we can talk a few more hours, just a few more hours to talk about all the possible research projects. But yeah, like I think part of it is that there are some scales that are designed to check the arousal and like those kind of things with the stimuli. But I think it's highly related to like the how do we measure self-awareness using EEG, if there's any ways of doing things, and what do we mean by self-awareness? Is it being aware of our emotion or our thoughts, or what do we mean by that, and how do we measure that?
Okay, so when you're defining it, I would hope you please consider that self-awareness can actually include noticing a brain state change. In other words, the things that show up on the EEG, I believe that if we practice self-awareness, I can tell you when the I don't mean I can, but one can tell you when certain changes happen on the EEG, that those are very experienceable if we become attuned to paying attention.
I completely agree with that. I see that a lot when I do skills with my clients. I mentioned earlier, I do brain spotting. I do other therapies too, like emotion focused therapy, and I kind of integrate skills from somatic. But it's really interesting. Like with brain spotting, I can see when the parasympathetic kind of kicks in. You know, when my client's body relaxes, I can see them exhaling. Maybe they start yawning. So I can definitely see the shift.
So then why do we need EEG anyway? Right? That's the question.
One of my research interests is to actually use brain spotting, kind of see like what's really happening inside. I have like so many.
Yeah.
I think it can be very helpful to build that awareness. I know I worked with a counselor at one point, and she connected me up so that I could learn how to do equal breathing. But just being able to see what my brain was doing, what my heart was doing, allowed me to correct. You know, it was a visual indication. And so in seeing that and using that to correct, then I could do it without the machine. But I can tell you, having that machine tell me, what was going on with body and brain,